Hi, everyone, and welcome to another episode of Sarcoma Sisters. We're so excited today because we have Dr. Lor Randall with us, and he's the chair of the Department of Orthopedic Surgery at the University of California, Davis, and is a true expert in orthopedic surgical oncology and is probably on every COG trial for sarcoma that I am aware of. And we are just so excited to have him here with us today. So welcome, Dr. Randall. And I think to kick us off, we've been asking people, because it's always great learning for us to know too, what led you into orthopedic surgery and then oncology and sarcomas? How did you get to the space where you are today?
Well, first of all, thank you for inviting me. I'm humbled to be here. I'm sure you have a lot of pediatric oncology specialists in sarcoma, and I'm very grateful for the invitation. So thank you so much, and it's wonderful to connect with you both. So I initially loved surgery, obviously in medical school. I knew that surgery was what I wanted to do, but I thought I was going to do general surgery or pediatric surgery. But I did a rotation orthopedic surgery, and I said, these guys and gals are fun, and they do some really neat surgery. And so long story short, I ended up going into orthopedic surgery. But what was interesting in orthopedic surgery is I missed some of the intense discussions and the issues that we took care of with patients in general surgery and surgical oncology in particular. And so long story short, I felt that orthopedic oncology was just hand in glove fit for me, because I got to use all the tools of orthopedic surgery, which are fun and amazing. And yet I still got to walk the walk, the privilege of helping people struggle with their issues of cancer and the family struggling with cancer.
Awesome. Thank you so much for sharing that with us. That's I think, that's what brings a lot of us to pediatric oncology for sure as well. And I know in orthopedic surgery, we'll get into a lot of questions with orthopedic surgery, I think in general first, because there's a lot of questions that come with that. But I know you also do some translational research as well. And so I was wondering if you could just talk to us a little bit about what you do, and then we'll get more into the orthopedics aspect.
Sure. So professional research endeavors over decades come in chapters. The first chapter was running my own wet lab back in my prior institution, and I had a background in gene expression. And so I had a gene expression lab, and then I started asking questions around sarcomas that had translocations, such as Ewing sarcoma, synovial sarcoma, and a variety of others. And I started harvesting samples from patients' tumors and built a very large repository of these genes, these translocation genes from tumors, and then started working with Nobel laureate Mario Capecchi to build out some mice and things of that sort. And then I brought in my partner, and this really blossomed out. But I've had this very long interest in translocation biology, which I've still worked with Josh Schiffman and obviously Steve Lesnick in the past. Those connections are still true today. But I've moved on a little bit. I do a little bit more of metastatic carcinoma tumor microenvironment, which isn't really so much sarcoma related, but it does deal with a more common form of cancer that spreads to the bone. And I do some microenvironment work there. But then my other latest passion, which does relate to sarcoma, is healthcare disparities. Obviously, that's a forefront on everyone's mind. And so I've been working with some public health scientists here at UC Davis to really drill down on outcomes for patients afflicted with sarcomas based upon socioeconomic variables, socioeconomic status, ethnicities, and then obviously adolescent young adults, which you and I both have as a common passion. We know that AYAs struggle in that domain too. So a bunch of different areas of interest.
Yeah, no, I don't even know how you have time to do all of these. That's so amazing. And it's funny, because I was going to bring up the adolescent and young adults, because you actually started this this sarcoma clinical trials working group that I'm a part of, and actually Wendy is too. She's building out an AYA program at Mayo. And now that I'm in industry, it's just from the from this up, this is like what I get to do still, to be part of the AYA community. And I am interested to hear what you're doing with this, with the disparities at UC Davis. How are you guys conducting your research? What kind of what are you looking at and how are you looking at it for these disparities? And is it just AYAs, or is it like I think you said it's like class effect, and is it race, and what else are you looking at?
So one, we're doing it in a variety of fronts, but Brad Pollack, who's the chair of public health sciences at UC Davis, is a good friend of mine. He's one of the reasons I came here. Obviously, he's involved with AYA outcomes at COG. So he and I have this pet passion together. But we've done everything from looking at the large NCDB, National Cancer Database, and SEER data, and the California registries to look at socioeconomic status and tiering them, and then looking at outcomes. And now what we're trying to do is trying to get some working groups together to help us inform our decision making around access to care, and then what sort of resources are necessary for patients that are struggling, because it's not just insurance status, but it's all the other aspects that go along with having resources or not having resources. And so what we've done now is partnering with the School of Nursing here to look at this and building these working groups.
Cool, that's really exciting. Yeah, I saw a paper Mike Roth had just mentioned on his Twitter the other day that they published just looking at financial toxicity in cancer patients, and then they had a case specifically on AYAs. But I know it affects everyone, and like everything, we probably need an upstream effect answer, from a higher stance, like where do we do this from, like political and in getting our patients access and money, but what can we do at our level as well, so that's really cool that you guys are doing that. That's very exciting. And I guess we should actually talk about orthopedics too. But all these things are so important that you're doing. That's really great. But first of all, let's see if Wendy has any comments or questions on the AYA before we talk more about bones.
Oh, well, I think the bones and the AYA and the sarcomas are all related.
Yeah, it's true. It's true.
But I do think, I think it's time that we start doing this research and disparities and outcomes and access and stuff. We still have room to go on biologic outcomes, but even the best orthopedic sarcoma surgery results in downstream effects for the rest of their life, and limb differences and all of those things that require continued engagement with the healthcare system, which I think those disparities get wider and wider as the patient becomes a survivor for longer and longer. And so I think it's another piece that we need as part of the puzzle to make them healthy survivors. And so it takes everybody from the bench to the prosthetist to the insurance company to the government. I think that's what you're referring to.
Yep. It wasn't coming out right, but thanks,
Make
Wendy.
it all happen. So yeah, it's very cool. I wish I had time to do everything that I wanted to do.
It's tough juggling it, right? The key is to takes at least a village, and to find ways to make sure everyone feels engaged and appreciated to move the needle on these issues.
Yeah, sure. You want to talk about the bones, Lisa?
Sure. Yeah. So, I know as an orthopedic surgeon, when we think about the sarcomas, we think primarily about Ewing's and osteosarcoma. And I guess for when a patient is initially diagnosed, of course, in pediatric oncology, usually they'll see an orthopedic surgeon, but they get chemo up front, and then we'll have surgery and see you for that surgical procedure. And I think just from the beginning, how, if you're a parent and maybe are at a smaller center, how do you feel confident and feel okay that you're getting the best surgical options? Do you think that they should always ask for a second opinion, or what do you think that parents should do, especially if they're at a smaller institution?
It's a great question. And just before I answer that, I'll say that while as an orthopedic surgeon, I do a lot of bone work, the soft tissue sarcomas are really a passion for me. So obviously synovials, which are largely AYA tumors, right? It's sort of the prototypic AYA tumor, and then obviously rhabdos. So just want to get that plug in there as an orthopedic oncologist, that we also care about the soft tissues and not just the bone. But back to your query.
You saying the muscles are attached to the bones? Is that what you're saying?
What? Yeah, no, very, very good point. Thank you for bringing that up. Yeah.
So I think the really fundamental aspect of this is that when someone goes and sees a sarcoma doctor, whether that be a pediatric oncologist or an orthopedic oncologist or a pediatric surgeon up front for a lump and bump, or they're being referred after they're seeing their pediatrician, the really fundamental question is, are they a team? And then the next sort of question is, are they at a facility that has really a verified sarcoma program? And how do you say what determines this verified sarcoma program? You can get pretty cantankerous with the opinions around that. But I think ultimately they should be at some sort of National Cancer Institute facility, NCI facility, where there's that check rein of quality about team approach to delivering the care. But more fundamentally, I think when they see the doctor at the sarcoma group, sarcoma clinic, what have you, they should say, so do you guys meet regularly? Do you meet on a weekly basis to talk about all the kids that are going through this, or the families that are going through this? I sort of use the analogy of air traffic control, right? We've got some airplanes that are taking off. We've got some that are at cruising altitude, and some that are coming in, and some that are coming in hot, right? With fever, neutropenia, or what have you. And we've got to navigate all these things. And we need to have the doctors and the nurses and the allied professionals all working very synergistically. And so again, what I would say to families is, when you go to see that doctor, ask them if they really have a devoted group of individuals that will take care of their child through this year of treatment and more.
I like that air traffic controller analogy. I always say I'm like the railroad conductor or something, but I think, in these multi-D teams, somebody's got to do the air traffic controlling and the conducting. And sometimes that falls on me and sometimes it's other people, but I like that because there are so many different things going on all at one time amongst all of the patients. So that's a really good way to ask it. I get that question a lot about, should I do my surgery here? Should we do it, elsewhere? We have a lot of people referred in up here in I guess we're the upper Midwest. Some people might argue that nuance, but I guess we're the upper Midwest. And I like that question of, just a simple way to assess, do they have that infrastructure to make it all happen? And sort of behind the scenes, we know that means the tumor boards, the pathologists, the radiologists, and everybody's there meeting. But that's a good, easy question. I had never thought of asking it that way. I like that.
Yeah, it's if we think about all of the challenges in healthcare, one of the biggest one is communication breakdown, right? Mm-hmm. From the wrong doses of IV antibiotics to wrong side surgery to more global ideas. We really need to make sure that the physicians are talking in real time.
Did the air traffic control analogy come from if hospitals should fly book?
That's right. Yeah. That's right.
So when in your personal practice, Dr. Randall, do you meet patients if they come through a different avenue, they're not referred to you for a bone lesion incidentally or clinically found? Do you meet with them up front, or do you meet with them sort of after they've started chemotherapy? What's your preferred timeline of entry into the care team?
Earlier rather than later. With the new diagnosis, we, like most, hopefully, sarcoma panels or sarcoma boards, they meet regularly, and we make sure we go through all new patients. Now, because I'm chair, my clinical practice is a little bit reduced, but I have a fantastic partner in orthopedics, and we have some in surgery and pediatric surgery. We still all convene, and we still all make sure that the surgeons are involved up front. Sometimes we're doing the biopsy. Obviously, many of the times they're done through image guidance, but we really want to talk to them up front. And then when we talk specifically about the bone sarcomas, it's really important in children. It's really important that we talk to them up front because there are so many different reconstructive options for the limb salvage surgery, and including the pelvis and spine. You can go in a variety of different ways. And so you need to get to know that family. You need to listen to that family. You need to hear their expectations about little Johnny or little Jane, and whether they have visions of being highly athletic or they have ideas of being highly intellectually aspirational. What are the pros and cons of both of those? Because the treatments we tailor to them are predicated upon expectations, assuming, the vast majority of these patients will fortunately survive their disease, but they will then be left with orthopedic disease, which will encumber them for the rest of their lives. And so we need to make sure that we have some discussions, and that you can imagine, you don't even need to imagine, you realize it, because we deal with these poor families all the time. Their immediate response is, oh my gosh, my kid's got cancer. Is he or she going to survive? Right? And then you have to ask this other question, well, what are we going to do with the involved area when we have to resect the tumor and then reconstruct it? And they can't process all that information up front. And they're hearing about algorithms around chemotherapy and potentially study design or study questions that are being enrolled on a study. And so they're just overwhelmed. And so you need to have some very high level discussions. And as a surgeon, my part in that discussion is to say, we're really sorry that this is happening. Let me assure you, we're going to do everything to save your child's life. We will hopefully be coming to a point where we're going to be removing the tumor, and then we need to talk about what we're going to do to reconstruct the area where we remove the tumor. They immediately ask him, is my daughter or my son going to lose their leg, lose their arm, what have you? He says, in all likelihood, no. But we're going to give them the best function possible, and we'll talk about it. And then we see them again, probably around week 3 to 6, somewhere in there. And then obviously I have another conversation prior to local control around 3 months, week 11 kind of thing. So we want to have at least 3 points of contact. And for some of the kids who would do rotationplasties or claviculoprohumeri, some of these biologic reconstructions, if they're resourced, and the nice thing is that now we have technology, I will have video visits with them every other week or every week during clinic to sort of say, let's just talk about this. I'm going to throw this wild idea out there about proposing that we put your child's foot on backwards to look at a knee, and they come white as a ghost. But then you say to them, let me send you some videos. You just think about it. We'll talk about it later. There's no decision being made, but they need to be stewarded through that process to be able to come to that question, to that answer. And 3 months is not a lot of time to come to that answer.
Yeah, it's I grew up in North Dakota in rural area, and then I practiced in Houston for a while, which is different. And now I'm sort of in between. And I think that, and I have a family member who had a sarcoma that was taken care of by a very nice orthopedic oncologist. And I think, that access to care becomes hard here. And I know there's been a lot of conversation amongst advocacy and parent and patient groups of, should every patient with a childhood sarcoma, be treated at a center like, you and I are at. And that's not always feasible for people, and they may need to, travel for surgery, but then it becomes hard. Technology is making it easier, but it's still not quite the same. And so it does become hard to interface with different teams and try to get the surgery team woven into that ongoing, pretty intense chemotherapy at the beginning. And so that's something that we struggle with here. I think we do as good of a job as we can. There's always room for improvement, but just sort of like on the backdrop of the way I grew up in a very rural place, and things were far away and we had to drive all the time. It can be challenging. And I know there's people on both sides of the fence of, should everybody move to a sarcoma center? And there's not a one approach fits all kind of scenario, but that stepwise education in the midst of going through chemotherapy can be challenging, depending on where you're located and what your resources are, technology, travel, all of those things. And so I wish that our healthcare system acknowledged that and provided more support for people to travel or get the opinions that they need. So that's something I'm learning up here.
Yeah. And, elaborating on that a little bit more, I think it's as an orthopedic surgeon in that conversation, I think it's very important. The onus is on us to talk about all the options, whether we necessarily like them or not. So again, I've already brought up rotationplasty. There are surgeons who don't think it's the right operation, but that's a personal personal decision. There's plenty of data to show that it is a good outcome. There's plenty of concern about some of the cosmetic effects, but that's a personal decision. And so if one doesn't like to do it, they still need to, the orthopedic surgeon still needs to have that conversation with them. Say, you know, I'm not really a big fan of this procedure. I'll tell you why, but it is an option. And if you want information on it, you should go see someone.
Yep.
And I can tell you, I saw a family up from San Diego soon after I got here, where they were never presented with an option for rotationplasty early on, and we had to make that decision very, very late in the game, and it made for a very awkward social dynamic. And I think it's important that we lay these things out up front. And again, making it more of a personal issue. I am not a fan of big endoprosthetics in very young children. My personal belief and experience is that over time they won't do well, but that doesn't mean it's not an appropriate option for some families. And if I recommend against doing it, I certainly want to make sure that they understand there are people that advocate for this. And if you're not comfortable with my opinion, please, 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 let me send you to so-and-so who can talk to you about this. We can set up a video visit so that if you do want to do this, here's someone who has a lot of experience in it.
And I think, you know, you touched on this a little bit, but I think the important thing for sort of our listeners is that these options, we can kind of, you know, bucket categorize them into, you know, for limbs at least, amputation, and then reconstruction, and sort of some fork points in the reconstruction. But the first thing is always, is it going to give us good cancer control? And then the options fall from there. And so I think any good orthopedic oncologist, you know, that's the number one thing. So if an option is presented, then it is assumed that that will provide good cancer control, because that is the first and foremost decision point in the tree, correct?
Yeah, that I'm glad you emphasized that point. It's absolute job number one. Because if you don't get the cancer out, we know that local, especially in osteosarcoma, we know that local recurrence is a very bad situation. And so goal number one is get the cancer out. Goal number two is what do we do from that point forward? But there's no point in jumping to that next step if you haven't achieved goal number one.
Lisa?
Oh, I was just going to say, can you just explain just in simple terms, you know, what the rotationplasty is and an endoprosthetic, just so people,
Sure.
in case people aren't up to date on it.
Right. So generally speaking, most of these bone sarcomas and extremity and soft tissue sarcomas happen in the extremity, at least the alveolars. And in the bone sarcomas, we have to usually resect a large piece of bone, and that often will involve removing the joint. So if it's in the lower thigh bone or femur, it's about the knee. We have to take out the femur bone, but because it's a joint, if you take out the femur bone, you need to have something that goes with the tibia bone, the shin bone. And so you have to reconstruct the joint, not just replace the bone, it's the one bone. And so in the most simple of terms, we can use artificial devices like knee replacements, but they're bigger because you have more anatomy that's been removed. We sometimes will use bone transplants called allografts. And then often in younger kids, we'll use their own body to reconstruct it. And if you think about it with rotationplasty, and it sounds very scary, very socially awkward at first, but these kids are some of the happiest kids I know, frankly. But if you think of the ankle joint, just think about one's own ankle joint. It's basically a flexion extension joint. So is the knee, but they're 180 degrees rotated, right? They're like the elbow. This could be the knee. This could also be the ankle. It does it, but they're rotated on each other, right? Like this. This is my knee flexing, and this is my foot coming up. So what we do is, if we have to take out the knee, we take the ankle, and now the foot is like the shin bone. This is the thigh bone. And so it flexes, and it works like a knee joint. And it's the foot on backwards. And people go, my gosh, that sounds horrible. But these kids, they speak for themselves, because It's not an amputation, because in my mind, an amputation means you're transecting nerves, you're transecting tissues, and you're left with a residual stump, residual limb that is not a regular end-bearing organ. In a rotationplasty, you are taking the foot and you are making it into giving it a different function, but you haven't transected any nerves, and the foot and ankle are still functioning to move the locomotive apparatus and move this musculoskeletal system through space. It just does it 180 degrees backwards. Does that make sense what I'm saying?
Yeah, and we can
videos.
I was just going to say, we can link to a video with our podcast too, if anyone's interested, because it is interesting to see. But I think, like you said, and I'm sure that you probably refer your patients to talk to other families who have had this done, because it is amazing, like you said, how much function they can have. And that makes me think about too, what when you're having these discussions with teenagers, somebody under the age of 18, how much are they involved in the decision making, and how do you explain it to them? How do you do that? Because I know AYAs are so important to you, so I'm sure this is something that is really important to you too with the discussions. So, and have you ever been in situations where the parents and the kid disagree about what they want done?
Oh yeah. So if I may, I'll give you an anecdote on this. So
Yeah.
I was always intrigued with rotationplasty through training, through fellowship, but I never did one. And I never did one in fellowship. And I went into practice, never doing one, but I was always intrigued by it. And I thought, this is a fantastic operation. Finally, I got a family, a young lady who had Ewing sarcoma of her proximal femur resected when she was like 2.5, and they put an endoprosthesis in. And then she went on to have a bunch of complications, was in an abduction brace. I ended up meeting her around age 8, and we did a bunch of things to try and salvage the situation. But the long and short of it, she was really starting to fail. And I talked to the family about something called a double rotationplasty, actually, where you make the knee into the hip and the ankle into the knee. But let's not make it complicated. Let's just say it's a rotationplasty, okay? And the mother was aghast. And this is around 2008 or so. And she would have nothing to do with it. But finally, as the daughter came into young adolescence and we're struggling with this issue, she goes online and hears about it. And she finally convinces her mother to let me do it. I'm so excited. It's my first one. And the mother says, okay, we're going to let you do it. How many of these have you done? And I said, oh gosh. I said, none, but please don't let that stop you. It is the right operation. And if you're not comfortable with me doing it, I get it, but please, this is the operation you need. I can send you to a couple other places around the country where I know they've done a ton of them. I ended up doing it. But what has really happened is rotationplasty has come back more and more because of social media, and kids now, what kids learn by the young learners learn by an entirely different method than my generation and even your generation.
Mm-hmm.
And they get information in real time all the time. And the forums that I know, like social media, Twitters and LinkedIn and Snapchat and all that stuff, those are even antiquated. They've got these whole universes out there, and there are rotationplasty universes, and there are kids who are talking to other kids. They know, oh my gosh, my sister was just diagnosed with an osteosarcoma, and all these kids swarm into this chat room and talk to them about it. And what they're telling, and it's really a meritocracy, they're telling each other, the rotationplasty kids for the most part are saying, I haven't seen my orthopedic oncologist for years. And then the endoprosthetic people are saying, well, I'm going in for my bushing change, my 6th operation in 10 years. I love my orthopedic surgeon, but I'm having another operation. And so more and more families are now coming to those initial counters saying, you need to tell us about rotationplasty, which never happened, before 2010.
Yeah, I actually wrote down on my paper here TikTok, because I get a lot of people find out about it on TikTok. And I was going to bring that up too, that I think, we can certainly link the videos, and there's some nice, like, sort of like nicely done or polished videos. But I don't think that's what the patients want. They want to see, like, okay, well, how do you get out of bed in the middle of the night and go to the bathroom if your foot's backwards? How do you wear high heels? Like really practical questions of what is everyday life with this reconstruction look like? And that is where social media absolutely helps, because they're, now TikTok can do like 6 minutes, but these 30 seconds to 6 minute videos of people just living their lives and being pretty authentic about it. And so I think that is more helpful than a nicely polished video from UC Davis or Mayo Clinic or wherever.
Right. Well, and I appreciate that point, and I want to bring us back to the initial tenor of the discussion, which was these are very nuanced decisions that are for everybody. And I don't want anyone to come listen to this and think, oh, my son or daughter should have rotationplasty, or I want a rotationplasty. It's I need to consider it, and maybe it's right for me or my family, but maybe it's not. And there are downsides, and there are problems, and there are risks. So I want to be very measured in how we discuss about this, that it too has its limits. Unfortunately, any option for limb salvage has its limits.
One question that people will ask me that sometimes they won't ask my surgeons outright, which I'm not sure why that is if I have an endoprosthesis about the knee for a distal femur lesion, if I don't like it, can I get a rotationplasty in the future?
It's a great question. And the answer is yes, but the downside is the risks are higher because you have scar tissue. You've gone in and surgeons curse scar, but frankly, if we didn't have scar, we'd never have success because wounds wouldn't heal, right? So you need scarring. And you dissect out these vessels off the tumor, and so they get a sheath of scar around them. So now, rather than having, I'm not a pork eater, but the analogy I give is a strip of bacon. Before you cook it, it's nice and pliable. If you cook it, it's brittle and it'll snap. Scar tissue is very similar to that. So now in the rotationplasty, you're shortening the limb and rotating it around, and you're twisting those vessels, and now you have risk of much higher risk of injury to the vessels. So that's a long-winded way of saying yes, it's possible, but the risk to the nerves and the vessels are higher. The other thing is the growth remaining. Without getting into too much detail, if you do a rotationplasty in a younger patient, you have the other limb has so much growth remaining that the involved limb, you don't shorten that much. And they actually walk for many years with one knee, or the ankle that's serving as the knee, lower than the other, because the other one's going to grow to it. As you get older, that growth remaining on the uninvolved leg is less. So you have to shorten this one more so that when they're done growing, they're at the same level. And the more shortening you do, the higher the risk. So doing a rotationplasty in a 6-year-old is far more challenging than in a 16-year-old. Does that make sense?
Mm-hmm. Yep.
Yeah. I'm thinking people really need to watch the YouTube of this so they can see the hand too. And by the way, that bacon analogy is amazing.
I was going to say, can we name this podcast Scar Tissue as Cooked Bacon?
Yes. No, that was great. I was going to ask, I'm going to give everybody too in the show notes a link to your Twitter, because you on LinkedIn and Twitter, you always have such good information and are such an amazing high fiver and advocate for all your people, by the way, which is so cool to see. But I saw that you just linked to a paper that you did in Ewing sarcoma, looking at one of the most common places that Ewing sarcoma occurs in the pelvis. And so usually the go-to is radiation, but I saw you actually published a paper on that, talking about surgery versus radiation. So I just was wondering if you could tell us a little bit about what you found and what your research was on that.
Yeah, so this is a question that's near and dear to many of our hearts, particularly in COG. And we tend to use radiation radiation is an absolutely acceptable modality for treatment for local control in Ewing's, right? That's not a controversial statement. It's also, we've learned that patients who local recurrence happens with surgery and it happens with radiation. It tends to happen more with radiation than with surgery. But that's not to say that surgery isn't as good, or excuse me, radiation isn't as good as surgery. It's because the patients that get radiation have the bigger, badder, more difficult tumors. So there's a selection bias. We're treating the bad ones with radiation and the easy ones with surgery. So of course the surgery looks better, right?
Mm-hmm.
And that's not totally a true statement, but for the sake of this broadcast and for people to understand, that's why the naysayers say that, you know, you can't throw radiation out and we need to use radiation, and we will tend to use it in the pelvis and the spine, definitely in the spine, just because the role of oncologically resecting the entire Ewing sarcoma is more challenging in these anatomic areas. But with certain cases with surgery, if you can't get them out, they do quite well. And I know over in Europe, there was that consensus meeting. Did you go to that consensus meeting back in London, like 4 or 5 years ago? No, there was a really nice European transatlantic consensus meeting in London, and we put a paper out on it, where the Europeans are tending to do combined modality treatment. And here in the United States, it's either or. And I do think there is a role for combined modality treatment, where you do a lower dose preoperatively, and then you go in and resect the tumor with negative margins, but it's easier you can do a less aggressive surgery. But we've tried to get some traction on that through the Bone Local Control and Children's Oncology group, but we haven't really gotten there yet. The paper we just published was just another statement to say that we haven't really proven that one is better than the other, and we should either do a randomized trial, which is very hard to do because the treatments are so disparate, or potentially look at some sort of combined modality treatment.
Yeah, that's interesting with the combined modality, because that's what that would be my question for you, is if it, I guess my understanding, which may not be right, is that if you do radiation first, then it's harder to do surgery. But I don't know if that's true with orthopedic surgery.
So it all depends upon the dose, of course, but and the timing. So if you do upfront radiation, and these are generalizations, obviously everything is nuanced, but if you do upfront radiation, there's a 4 to 6 week window where you don't get that fibrosis and scarring from the radiation. That's a good local. So you could do upfront radiation and go right in. If you do radiation and then go into surgery, 3 months later, then you have really big complication rates.
Yeah, that's like the bacon that's crispy.
Yeah, right.
Yeah. Right. I get it. No, cool. That totally makes sense.
Yeah. We're getting short on time already, but I wanted to. This might jump around, so you might have to edit it, Lisa. But in thinking of, this is what I do to her all the time. In thinking of, you guys are continually sort of refining what you're doing with your surgeries, and we know with pretty good certainty like what our margins need to be, and things are getting refined. But what do you think is the next thing for orthopedic oncology? Like, is there going to be a next big thing? Like, where is your field going?
Bring a prop in. So
is it 3D printing? Like, what are we doing here?
This is and here, hold on.
So glad you asked this question. And look at all Dr. Randall's certificates.
Printing. It's here I am. I feel like Mr. Rogers show and tell.
No, we love it.
So this is a 3D printed model of a bone sarcoma. This is a femur. And what we do is we have all of these custom guides that we take a CT and an MRI of the patient, and we then have a real-time session with a vendor that then will make these 3D printed cutting guides. We use them particularly in the pelvis. Sometimes we'll use them in the extremity, but these grooves here that you can see literally fit right on the bone and allow you to make complex cuts so that you can leave more bone behind, as opposed to just doing a transverse cut. And in the pelvis, it's amazing. I have a session next week on a pelvic case where we've got a recurrent sarcoma right around the acetabulum. And before, we'd either have to use navigation, which would mean big exposures, or we would have to use, we would use navigation. But now we can use these cutting guides, do all of our intellectual homework, if you will, ahead of time, go in, expose these areas, put these cutting jigs, and you literally slide them along the pelvis, and they sit exactly where they need to be. You pin them, you make your cut, you take out the tumor, and then just like a jigsaw piece, puzzle piece, you just put in the tumor or put in the prosthesis, and it already has the direction where you put your screws in to get things where you want them to go. So you can imagine in the pelvis, when you're trying, in the olden days when we used to make these things, we sort of have to figure out very carefully where to drill a screw and not hit a vessel or hit a nerve. But right when we do it ahead, when we drop the implant in, it's already got slots for us to put the screw in. We know exactly where it's going to go. We know exactly the length, and it takes the stress off the surgeon. More importantly, it reduces the time in the operating room. And importantly, you get that kind of press fit interface. And so it's really exciting technology, and it's only been around for a few years, and there's a few companies that are really pioneering it. And so 3D printed custom jigs and implants are the
IKEA of the pelvis, just like putting it together.
Yeah.
Yep.
Stencil, cut it out, put it together. You get 75 pages in Swedish instructions.
Just the pictures, no
That's
words.
really neat. I didn't realize that was ongoing, or I haven't heard about that. Before.
Yeah, and who's it
Cool.
available to? Can all patients get that, or how does
it's commercially available now.
Wow.
Yeah, so that's a question. Sorry,
could you say that again?
That's my Siri. A family should ask, especially in the pelvis, they say, are you using 3D printing cutting guides and things for your surgery? Because it does, obviously technology adds expense, but I think this is a value equation. I think we should do this study. The reduction in OR time because of these jigs, really, I think it's ultimately a cost savings, but that has yet to be proven.
That's really cool. Is orthopedic oncology as a whole thinking about or concerned about our increasing interest in tyrosine kinase inhibitors and wound complications?
Yeah, for sure. Absolutely. Yeah,
we'll find out more information with the upcoming osteosarcoma trial. But, I think if we think about pediatric oncology from a medical oncology side, I don't think TKIs are going to be the everything, but I think they're going to be a part of the puzzle. And for every action, there's a reaction. And I think in these bigger surgeries, this is where we're going to have to come to some sort of compromise, between the two avenues. And who knows what the next agent of drugs is going to be, that may or may not have wound complications. But I bring that up only to kind of sort of point out that none of what I do, Lisa does, or you do, is in a vacuum. And it really is this big team approach, and we have to be thoughtful about all different pieces of it, which can sometimes be hard to be patient for as a family, and to really understand that it all works together in this big jigsaw way, sort of like the cutting guides.
Well, and it's multimodality therapy. I recently watched the PBS series Emperor of All Maladies, which is obviously there's the Mukherjee book, and this is he editorializes, and it's a really nice mini series. But I would encourage all family members to read this, because or watch this. Excuse me. It's not the book. It's different, but it talks about the history of cancer, and then how we've gotten where we've gotten, and the fact that cancer, like humans, is evolving at a much faster pace, and that we have to learn to live with our disease, and the multimodality treatment, the multi-TKIs, and the roles of immunotherapy. It is a very exciting time in the war on cancer, so to speak.
Yeah, definitely. I watched that a few years ago, but now I want to watch it again. But right, I remember even just talking about, how they used to do high dose chemo and transplants with all the breast cancer surgery, and then we found out that didn't work, and how it's always evolving. And I think when you're the one living it and practicing it, or either having the cancer, we're always trying to do our best and trying to do what the best is for the patient. But sometimes we don't know until we look back, was it the best or not. But yeah. Wendy, did you have another question?
Is there any, I always have a ton of questions. Is there anything similar with your 3D printing for soft tissue sarcomas, or what's going on in that realm? What's the next thing for that?
In soft tissue sarcomas, I think the surgical aspect is not so much the latest and greatest. There are some exciting research going on at looking at ways by which you can either assess the tumor bed for microscopic residual disease by looking at signatures of certain cells, or also imparting local therapies actually directly into the wound as opposed to systemically, when you have a very precarious margin. We're constantly peeling tumors off. They've usually had neoadjuvant chemo in the pediatric setting in particular, and they've had preoperative radiation, but there's oftentimes you're taking that string away from the meatball, so to speak, and you're just worried that there's residual tumor. And so there's thoughts around, can we be delivering agents right along that neurovascular bundle to prevent local control? So that's, I think, one of the next big things coming along.
The other thing I just realized, Lisa, that people may not know is that for spine tumors, often orthopedic oncologists are involved either alone or in conjunction with neurosurgery. And some of these sarcomas, these retroperitoneal sarcomas, and other childhood cancers end up along the paraspinal region. And so a lot of times that is a place where they will run into an orthopedic oncologist. And so again, same question. Do you think there's a role for this sort of this new technology in the spine? I apologize, I don't know. I don't think that you do spine surgery, but I'm not sure.
So I did. The issue with spine surgery is, even with immensely talented surgeons and immensely talented or immensely advanced technology, you still have very close margins by the nature of the anatomy. And so particularly in Ewing's, unless they have they need urgent cord decompression, we tend to treat those with radiation because it's, again, aforementioned, an acceptable form of treatment. For osteosarcoma, obviously, we have to do surgical excision. I think there probably could be some ideas around custom jigs and things of that sort, but usually you just know that you have to take out several blocks and obviously the posterior elements around the spinal cord. But I will tell you that the spine, one of the reasons I got out of spine surgery is it's evolving so quickly that if you don't do it all the time, you just can't keep up with the technology.
And there's I've even noticed in my short career, a lot of changes in the way that they're approached, and whether it's primary tumor or metastatic lesion in a vertebral body, et cetera, it's different than when I first started. I'll just say that. So that's cool. Okay, I'll be quiet so Lisa can ask a question with the last 5 minutes.
Yeah, well, I was just thinking, this is a question Wendy sometimes asks, but I think it's always a really good question from the expert. What are some questions that you think, and I know we've talked about some of them, but are just really important for parents to ask the orthopedic surgeon? I know we've mentioned a few things, about if there's other surgeries out there and technologies, but I don't know, anything else that you can come to mind that you just think is, you wish the parents would ask you, or I'm sure you usually talk about them, or just some good advice for parents and for their patients and for the young adults themselves to ask?
Well, we have touched upon the really salient ones, but I think they're worth re-emphasizing, which is asking the surgeon or the oncologist, how often do you guys meet? Are you part of a team? What's your schedule? how often are you communicating and reviewing my case? I think that's very important. And I think the standard really is on a weekly basis, more or less. But it doesn't have to necessarily be that frequent, but there needs to be a real sense. The family should leave that encounter feeling like they have a team behind them, not just a doctor. And then I do think being part of being an NCI comprehensive cancer center and part of some of these bodies that really make sure that we're delivering the best possible care is really important to be on the leading edge for these very aggressive tumors.
Yeah, and I think one, thank you for that. And one other question, I just think about the AYAs again. I feel like the struggle is real with the AYAs, with the adolescents and young adults, because they have so much going on in their lives. And I think once they're done with cancer treatment, they want to just be done. And a lot of times they can have problems with their prosthesis and they don't come in. And I think, like, what advice or what can you do to encourage the adolescents and young adults for once they're in survivorship land to get the best function out of their lives?
That's right. Survivorship is a huge deal, and going through the treatment is hard for AYAs because they're somewhat disenfranchised in that they haven't established their trajectory in life necessarily, but they no longer have the adult or the pediatric resources available to them. And so they struggle with the treatments, and then they're left with all the outcomes. And it's really, really tough. And I really have enjoyed working with you and others in this domain. I was very grateful when you gave that shout out at COG a couple sessions ago. It really put a giddy up in my step. I love the AYA arena, and I've really enjoyed working with you on it. So thank you.
Thanks. And I mean, you have done so much and continue to do. I mean, that's so exciting, all the research that you're doing. And I think it is going to have this upstream effect and make a difference. And so thank you for that and for being with us today. And I think parents and patients are going to find this so helpful and informational. And we learned so many cool things. We always do on this podcast. That's right.
This is a great, yeah. I love that you guys do this. It's a great forum for us as providers, but more importantly for families. So thank you for all that you're doing. Awesome.
Well, you take care, and thanks for being with us.
Yeah, you guys, good luck. Hope to bump into both of you at some point soon, and really appreciate it.
Thanks.